Hello, my name is Paul Wynn, and my project is on predicting heart treatment from intravascular ultrasound data. I have a background in arts and technology, and I work at a nonprofit arts organization here in Denver, Colorado, and manage a project called the Creative Vitality Suite, which is an economic tool for arts administrators to measure the impact of arts in a region. So my project, again, is on heart disease and the intravascular ultrasound procedure. Heart disease is the leading cause of death in both men and women in the United States and globally. What is heart disease? Well, there are coronary arteries on the surface of the heart, which and those arteries, when there is normal blood flow flowing through them, they're basically clean. So as you can see here in um, the chart here under B, the cross section shows no plaque buildup within the artery wall. Now, as someone ages, depending on their diets, plaque may build up within their arteries and restrict the blood flow through those arteries, which can cause stress upon the heart. Um, the blood flow is called fractional flow reserve. And when it's below a 0.80 threshold, it's associated with myocardial ischemia, which is a candidate, which makes the patient a candidate for stent treatment, which will help open up the artery walls to allow the blood flow to continue flowing freely through the artery. So what is ultravascular ultrasound? It's a imaging technique used to monitor stenosis, which is the narrowing of coronary arteries, and it evaluates treatment for heart disease. What this basically does is the doctors will feed a catheter through the arteries in a patient, and they will take images, along the artery wall. Those images, they look similar to this, but these are masked images. Basically, these identify the lumen and plaque area. When someone goes through this particular procedure, a few hundred or 1,000 slices are taken of the coronary artery walls, and these are the images that are kind of produced. The green area is the center of the vessel, and the yellow area is the plaque buildup. And as you can see, and then the outside of that yellow area, the border is going to be the coronary wall. So as you can see, as the plaque builds up, the lumen area, the center where the blood flows through, gets smaller and smaller. And again, that's that stenosis. That's the restriction, narrowing of the artery wall. So let's move on to feature extraction and exploration. So here's a chart of lumen area for a particular patient. Now, as you can see, there's a couple different sections here which kind of informed us on how to develop the features for this data. The distal, the lines here on the left and right side, the distal and the ostium, that right there basically is the boundary of the region of interest. And the lesion here is going to be the most narrow area within that coronary artery. The area in front, the distal reference, and the area behind, the proximal reference, those are going to be the areas on the outside. So again, each one of these areas are integral points for this particular patient, and which describes what might be happening with the blood flow in each one of these sections in the artery. So one of the things that I needed to approach when doing this project was that there was a lot of noise. So I looked at different smoothing processes. One was a convolution and Savitsky-Golay smoothing process. And I ended up going with the convolution smoothing because it generalized the flow of the lumen area just a little bit better. So here you can see the red line is the smooth um, data, and the light blue is going to be the raw data. So here's a little bit of exploration of the data itself. This is the actual blood flow, so the fractional flow reserve distribution. Um, the positive class is going to be below an 80 threshold, and the negative class is going to be above 80 threshold. So just from these distributions, you can see that the number of there's the majority class is going to be the negative class, and the positive class is going to be the minority in our data set. Here's a distribution of age within the data. As you can see that the majority of the patients are older, from 40 to 80 years old, with the majority or peak of age being between 60 to 70 years of age. On the right-hand side is the distribution, a box plot of age and FFR 80. FFR 80 is going to be our classifications. 0 is going to be our negative class, and 1 is going to be our positive class. And as you can see, looks like they're pretty similar in terms of age, whether or not they are positive or negative. The minimum lumen area, so earlier we discussed as the lumen area, the green section here on the right, as that gets smaller and smaller, the plaque area builds up, and there's more restriction for blood flow. Here is minimum lumen area by our target class, and as you can see, the minimum lumen area tends to be smaller for our positive class. So more lumen area equals more blood flow, less lumen area equals less blood flow. The next slide here is the number of frames above plaque burden 0.40. So we use plaque burden to identify the worst areas, otherwise called the lesions, within the artery. So the pink areas on the right-hand side are the lesions, and as you can see, there's a dotted line there for the threshold, the plaque burden threshold. And again, I created a box plot here to show how plaque burden is associated with our target classes. So our negative class tends to have a slightly lower median plaque burden than our positive class, as you can see there by the direction of the red line there. So correlation and feature reduction. We had over 128 features with this data set, generated with this data set. I did run the models with 128 features, and it didn't perform very well. So I thought we could use a correlation matrix to reduce the number of features. So here on the left-hand side is the matrix, the correlation matrix for 128 features, and on the right-hand side, we were able to reduce that down to 65 features after removing some of the correlations above a 0.9 correlation coefficient. I also used, before we move on, I did try PCA as well for feature reduction, but because we did, it didn't work as well in the models, which I can kind of discuss a little bit later, but it was tried. So the models that we used random forests, which is a supervised classification or regression. It's basically an ensemble of decision trees where root nodes and splitting of feature nodes are random. I used a number of different random forest models, which which included a technique called boosting, which basically takes random forest models but converts the weak learners into a single strong learner and gives misclassified samples higher preference, which increases the predictive force, and it uses a weighted majority vote to identify the weak learners. So we also tried eta boost, gradient boost, XG boost, and it's not a random forest, but support vector machine learning, which uses a higher dimension plane to divide the data. And we can kind of discuss those results a little bit later. Some of the random forest parameters that were used were number of estimators, which is the number of trees to build the max depth, so the depth and size of the tree. The minimal samples leaves, so the number of samples at the end node or the leaf node. The minimum number of samples required to split a particular node, and the max number of features to consider when splitting. So the results. Before we talk about the results, I just want to discuss the evaluation metric. False negative rate was probably the most important metric used in this project, which is the probability of classifying a positive event as negative. So in healthcare, a false negative rate is probably one of the more important metrics to make sure that patients who have a particular disease are being treated for. Also tracked recall, which uses false negatives as well. Tracked precisions, F1 score, and accuracy is not really important here, but I tracked it just to see how it's going. After producing the random forest, this is the top 20 important features that were found: age, minimum lumen area, the number of frames within the lesion area. So a lot of these features are related to the worst section within the coronary artery. And so that makes sense because when you're looking at the worst region, if there's a lot of plaque buildup, if there's a very small lumen area which is restricting the blood flow, that's going to raise the risk of whether or not a particular patient needs treatment. So I built 15 different models. These are some of the best ones that I pulled out here. The random forest tuned, support vector machines, eta boost, gradient boost, and XG boost. So we'll talk about a little bit about the results here. So from the results, I started with the random forest, and it did okay, but it wasn't anything impressive. And as I continued, looking into eta boost, gradient boost, and XG boost, the false negative rate started decreasing, which is lowering that probability of classifying a positive event as negative. It started lowering, and that's a good thing. Recall, precision, F1, and accuracy, those are metrics that you want to see to increase to 1. When they get to 1, that means they're near perfect. I found that when I tuned the particular models, they did much better. So when I used random searching and gradient searching to tune the models in order to find the optimized and best parameter that would get me the best results and best performance from the model itself. I had a lot of trouble with the support vector machines model, and that is because our data was imbalanced. What that means is that we had a minority positive class and a majority negative class. And it was about a 30-60 ratio there. The support vector machine just doesn't really work well with an imbalanced data set. So I ended up using SMOTE to resample the data, basically upsample that minority class so that both classes were similar or equal. After I did that, I actually was able to get results. They weren't very good, but I was able to actually get results from a support vector machine model. I also applied the resampling SMOTE method to an XGBoost and was actually able to get a more improved model than the previous XGBoost, which you can see highlighted here. So I highlighted all the best metrics, and it turned out that the XGBoost provided the best performance for this model. So the conclusion, the feature reduction, it helped a lot with the model performance. It removed a lot of the noise. Again, correlation, if you had multiple variables that were correlated, it was only necessary to have one of those variables. Otherwise, the other variables would just add more noise to the particular training process. I did PCA, principal component analysis, to try to reduce the features even lower. But I started seeing a loss of performance. I feel that the smoothing that we performed early on in the feature extraction process generalized the data enough where PCA wasn't effective anymore. That's my belief there. The XGBoost provided the best performance with a false negative rate of 0.38. Again, class imbalance was a challenge with this. So how could I improve this in the future, or how could someone take this and improve this? I think SMOTE and resampling the data to balance the classes is going to benefit the models in the long run, and definitely worth looking at in the future. Building ensembles of all of these models, combining the models to make a better predictor, I think could do well. Some of the models we saw earlier, if you were looking at the confusion matrix, some of them performed better in the false positives, and the other ones performed better in the false negatives. So again, that resampling is going to help with that balance between false negative, false positive. But in the event that two different models perform better in either one of those, if you were to combine them into one ensemble, you might actually create a better model that would be able to predict both better. And I think in the end, we need more data to feed the model. There is one feature I was looking into, which is eccentricity. And I think this would really help the model. Basically, it's using image segmentation to measure the diameter within the artery itself. So the lumen diameter would be the red lines here. You can measure the maximum and minimum distance within the artery wall, and you can also measure the thickness of the plaque as well, which are the blue lines there. So those are again some additional things that can be researched and added to the model to increase its performance. So that's the end of my project, and I hope you all kind of thought it was interesting. And if you have any questions, feel free to contact me at paul.myinbox@gmail.com, and there's my github.com account as well, where you can look at my code. And I wanted to say thank you to Regis University and to my classmates, as well as Geena Kim for providing me with the data for this project, and Nate George, our professor, who helped kind of guide us through the practicum this semester. So thank you, And I really enjoyed working with you all. Take care. Bye-bye.